Assalamu alaikum, everyone. Good evening, good morning, whatever time it is to you. I do notice some new participants with us today. And yes, there are some new ones. So let's begin. And do you people remember yesterday's, not exactly yesterday's, the last Zoom session about medulloblastomas? Can anyone unmute themselves and volunteer, please?
Assalamu alaikum, Dr. Kawal.
Walaikum
Uh,
salam.
can I try?
No, I just wanted if okay, isn't it a better idea if I can just briefly go over the previous slides so that anybody who is joining us today does not feel completely lost out?
Yes,
I
yes,
do
please.
have some previous slides. I don't have the yesterday's, not yesterday. I keep saying yesterday. I don't have the previous session's radiology slides in this one because otherwise this session would have been way longer than intended to be. But I do have some text. And yes, this elephant in the room is the molecular profile of medulloblastoma. And we are going to go over it very briefly. These are the histologic variants, the classic, the desmoplastic nodula, the medulloblastoma with extensive nodularity, and large cell or anaplastic. These are the easy histologic variants, easy to remember, easy to understand. This is the molecular profile, which was the elephant in the room. So we have wingless tumor activated. We have sonic hedgehog activated. Hello, Dr. Wilfried. Please turn off your mic. Please mute yourself. Okay, back to the molecular profiles. We have these four main groups. WNT activated, which is wingless tumor activated. Then we have SHH activated, sonic hedgehog. Then we have group 3, which are neither wingless tumors nor sonic hedgehog, and group 4, and they are also from the same category. So sonic hedgehog is then further divided in two groups, and these are the two groups. There are TP53 wild type and TP53 mutants. And why does it matter for us to understand this? Because both of these groups behave completely different from each other. So moving on to the next slide. Okay, this is just a visual representation of wingless tumors. Imagine the broken wings. The WNT activated tumors, they are a low to standard risk group. Let me annotate this so that it's easier for you to follow. They are a low to standard risk group and they favor the midline. Mostly, almost all have classic histology and their extension towards CPA via foramina fleschka or cerebellar peduncles is a behavior which is characteristic for them. How do you remember the extension? You remember it with the help of this graph. What do we mean by this graph, by the way, in its actual sense? Dr. Sana, would you like to volunteer because you were in the last session?
Yes,
Okay.
yes, yes. It is more in the children WNT activated group.
Yes, it is more common in the children age group. It's very uncommon in the infants, and it's also uncommon in the adult age group. But this thing here is also a visual representation. You can imagine that this is a tumor which is reaching out to the foramen of Lashka or to the cerebellar peduncles. So you see a tumor in the midline, and then it is extending like this. Okay, so we move on to the next slide. So wingless tumors, wingless WNT activated tumors, their prognosis is excellent for children with surgery and adjuvant therapy. In adults, even though they are rare in adults, the prognosis is very, very poor. So this is the sonic hedgehog group. I hope you will remember this illustration. Sonic hedgehog has two ears, just like Sonic has two ears here. And you can see these two ears going like this. Why does it matter for us? It matters because this is a bimodal group. What do we mean by bimodal group? That it shows two peaks in presentation in the infantile age group and the adult age group. So, their histology varies with the TP53 status. In infants, they usually prefer vermis over the hemispheres, and in adults, they prefer the hemispheres. I'm just going to draw a very cute butterfly, and you're going to imagine that this is a cerebellum, the midline being the vermis. So the infantile variant is represented by this orange color. This favors the vermis, whereas the adult hemispheric variant is represented by this pink. So if this was a cerebellum, infantile variant favors the vermis, whereas the adult variant favors the hemisphere. Are we clear till this? I'm going slightly quicker because we have already covered this in the previous session, and I have yet to upload the recording of that one. So, this is the wild type. Sonic hedgehog, TP53 wild type. Why does it matter? It looks really wild, savage in appearance, but it is not in its behavior. Its behavior is generally better than the other variant. So this is the actual group. This is the actual subtype within the SHH activated group, which is bimodal, presents in both the infantile age group and the adult. The other one, which is the sonic hedgehog activated, TP53 mutated, that is the other age group. That's not bimodal in its presentation. Let me write this. The actual bimodal group is the wild type one. The common histology in this is MBEN or desmoplastic nodular histology, and they generally have good prognosis. So, even though it looks savage, even though it is the wild type, like the image, I'll show the image, even though it looks savage, but it behaves better in comparison with its well-dressed counterpart, which is TP53 mutated. So, sonic hedgehog activated, TP53 mutated. This has a single peak in the childhood. The usual histology is large cell or anaplastic, and they generally have very, very poor prognosis. Am I clear till here?
Yes, yeah.
Okay, Dr. Kingsley, I'm so happy to see you today. So, group 3. These are non-wingless tumors, non-sonic hedgehog. They are the boring group. Since they are the boring group, they are also the most lethal subtype. And how does their graph look like? Their graph looks like an inverted pancake. Not, sorry, pancake, the frying pan or a saucepan. You can imagine a saucepan here. It peaks in the infant age group, then it peaks in the childhood age group, and it goes blank in the adult age group. This subtype often has leptomeningeal seedling, even at the time of presentation. The common histology is either going to be classic or large cell or anaplastic. Okay, moving on. This is group 4, one of the more common subtypes. It has better prognosis than group 3. So, we discussed the presentation in the previous session, and today we are not going to focus on the presentation. We are going to learn the risk stratification and a graph that is dreaded because it's in the Greenberg. We all look at it and we all conveniently ignore it and then move. Medulloblastomas are WHO grade 4 tumors. They typically arise from the roof of the fourth ventricle, fastigium or vermis. They make up 68% of embryonal tumors, and 10 to 35% have drop mets at presentation. Can anyone who has attended or listened to the recordings of the previous sessions tell me what is the rate of drop metastasis for high-grade gliomas? It's very easy to remember. Can anyone volunteer, please? Even in the chat box, that's fine. No one? Okay.
Yes, ma'am.
So 10 to 25%.
Hello.
Okay, yes, we do have a few replies. 10 to 25%. That is the rate of drop metastasis in high-grade gliomas, whereas in medulloblastomas, it is 10 to 35%. We have different radiology today than the previous session. So, who is going to unmute themselves and volunteer for the radiology? These are really easy ones.
Ma'am,
Okay, yes, Dr. Mustafa.
yes, ma'am. This is the MRI brain axial cut, showing the T1 weighted image with contrast, and there is a iso intense lesion at the in the left ventricle, in the lateral ventricle of the left side.
Okay, Dr. Lalita, you wanted to say something as well?
Yeah, hi, good evening. So, right, so I would like, okay, what I wanted to say was this is axial MRI on both the sides, T1 post contrast. So, what I can obviously see is the ventricles are grossly dilated. There are multiple enhancing lesions seen over here at the ventricular wall, the lateral ventricular wall at the septum, as well as there is dural enhancement, and there is also I think I would commit this to leptomeningeal enhancements for this case, for these two images, both on the left and the right.
That's right. So yes, there is extensive leptomeningeal enhancement. We can see some nodularity along the walls of the lateral ventricle. We can also see some of it protruding into the lateral ventricle. And there is significant enhancement around the, yes, around the ventricles as well. If you see, let me draw here. Um, if you see this region, the ventricular walls are enhancing.
Yeah, this
This is
ventricular
this is not
enhancement.
a typical behavior for a normal ventricular wall. If the wall is getting enhanced, either there is a metastatic process going on, or there is an inflammatory or infective process going on, and only then the ventricular walls enhance. So yes, there is ependymal enhancement. There is this granular lesions. There is some nodularity here, which is representing leptomeningeal seedling or drop metastasis. So continuing this image further. Okay, what do you see here? Dr. Lalita,
So
would you want to continue?
yeah, I would be happy. So on my left there is axial cut T1 post contrast, and on the right there is also an axial cut T1 post contrast at the level of the cerebellum and the pons. So I'll comment on the left image first. So here, what I can see is there is leptomeningeal enhancements, there is ventricular wall enhancement, there is engulfing. I don't know. I think engulfing of the ventricle by a iso to hyperdense lesion with periventricular nodules, minimal nodules seen. All right. So on the right, so T1 post contrast, T1 post ghetto MRI. Um, so there is, so okay. Is that, I don't know if that's the cystic part or the ventricle is, I
No,
think
that's
that's,
not the ventricle.
no, okay.
That's
So there
within the
is
lesion. It's the cystic part.
the cystic part of a lesion. There is a heterogeneous lesion in the posterior fossa. There is appearance of cystic center, could be a necrotic center with leptomeningeal enhancements as well, and also dural thickening. I'm not able to appreciate the fourth ventricle over here. I do not see dilatation of the temporal horns as well.
This
Oh,
is
sorry,
where
the
the
fourth
fourth
ventricle. Oh,
ventricle
sorry,
is.
sorry.
It's
The
very
fourth ventricle
small.
is there. Yeah. So the fourth ventricles is small and it could be displaced more to the right. I'm not able to comment further on the other ventricles, but there is gross leptomeningeal enhancements here, and there
What do you
is
think
a
is going on here? Do you see the folia? They are so beautifully enhanced in this entire section.
yes,
So
I
that's a very advanced level of leptomeningeal enhancement where the individual folia of the cerebellum are involved. As well, we can see some enhancement in nodularity here as well.
yep,
So this
mm,
is an extensive leptomeningeal seedling, and
mhm,
the patient is unfortunately going to have a very, very poor prognosis. So,
okay.
moving on to the
Okay.
next image. Yes, Dr. Fatma, you were right in the chat box. Yes, there is a gross nodular. Just give me a minute. I have an interruption. Give me a minute. Okay, I'm back. I'm so sorry for the interruption. Moving on, this section showed gross nodular enhancement and leptomeningeal seedling. There was also a lesion in the left frontal horn of the lateral ventricle, which is encroaching on the opposite side of the lateral ventricle wall as well. And you can also see the foramen of Monro dilatation. You can see third ventricle ballooning. So there is hydrocephalus, and then there is leptomeningeal seedling. Okay, so this is also an easy one. Dr. Mustafa, would you like to volunteer? Dr. Sana, anybody who are the regular attendees, do you want to volunteer?
Yes, ma'am. Yes.
Yes.
Okay, Dr.
Okay. Okay.
Sana.
Okay, thank you. Um, First image, I would like to start from the left one. This is a sagittal section of an MRI from the base of skull to the spine, and it is a plain image and showing the uh, T1 uh, T1 image with the leptomeningeal nodularity or meningeal nodularity, and on the second image that is also T2 T2
It's
images.
T1 post contrast.
T1, sorry madam, please
That's okay. That's
continue
okay.
with
You
that
can
image.
continue.
Okay, and T1 with contrast, and there is also a nodular lesion in the uh, dorsal lumbar spine, and the other one is T1 with uh, sorry, I cannot.
Yeah, it's the same thing. There is gross leptomeningeal seedling throughout the spinal axis. We see multiple nodules, and a very good word for these is sugar coating because that is how the sugar forms these crystals. I'm just going to mark these. If you look at these, the entire wall is nodular. And there's another thing. Even though this is not pretty clear on this particular image, the other sections that I saw were this tonsillar herniation because of the tumor up. So always take a look at the posterior fossa and then the tonsils, because if there is a lesion within the posterior fossa, it might cause mass effect enough to push the tonsils downwards and cause an acquired Chiari malformation. So moving on, I think that's it. The radiology for today. So this slide is repeated, ignore it. Are you all familiar with this chart? How many of you have seen this in the Greenberg and ignored? Dr. Ijaz, please mute yourself. Okay, somebody is writing in the. Oh, so yes, people have seen it and ignored in the comment box. There are a few who have not ignored, by the way. So brownie points to all those who have not ignored this because this is a very important image. If you understand this, you understand the post-operative risk stratification. And why are we going in the post-op risk stratification directly when we have not covered the other stuff of medulloblastoma? Because this image and the chart that you see for post-op risk stratification, they are linked. You understand this and you remember this, you are going to remember the other one as well. So let me move back. You have to thoroughly remember this first. Low risk is green, standard risk is yellow, high risk is orange, very high risk is red. Okay, what do you mean by 5-year event-free survival? This EFS is event-free survival. Let me write this. I don't think we are going to finish on time today because this is really important to understand. So this is 5-year event-free survival. What does this mean? That a patient survives 5 years without any adverse event regarding the symptomatology of medulloblastoma. For low risk group, this is more than 90%. For standard risk, this is 75 to 90%. For high risk, this is 50 to 85%. For very high risk, less than 50%. Let me move on to the next slide. So I want all of you to still ignore this very conveniently. We are going to come back to this at the end of the presentation. I want all of you to remember the histology for now. Only one, classic histology. We are going to proceed with classic histology in our mind. So this is our first group. What is this? This is a sonic hedgehog, very visible from the image. It is TP53 wild type. You can see its appearance. It does look savage, slightly wild. I don't mean any offense to any particular group, but it does look savage. Not very civilized, at least. And the histology is classic. So this is a TP53 wild type, sonic hedgehog, classic histology, because that was the histology we began with. And these are standard risk tumors. How do we know? Because this guy is wearing a yellow jacket. So somebody is writing something in the chat box. Okay. So are we clear till this? Sonic hedgehog, TP53 wild type, classic histology. They are standard risk. Moving on. These are TP53 mutants. They are classic histology, but we already know from our previous slides that the mutants behave worse than the wild types. So this guy is high risk. It's wearing orange, which is what our color code is for high risk. This is SHH, sonic hedgehog, TP53 mutant, classic histology. These are high risk, but the group is very, very, very uncommon. Now we will go back to this group. So this is classic histology. We are moving like this. Okay. This is sonic hedgehog, TP53 wild type. What was the group? It was a standard risk group. This is TP53 mutant. What was the group? It was a high risk group, but this is uncommon. Clear so far?
Yes.
So we will cover this step by step. Moving on. This is wingless tumors. So this is a superhero. Age is less than 16. Classic histology, dressed in a very classic attire. There are no mets. There are also no wings. You can imagine ChatGPT's poor attempt at trying to cut off his wings. He instead removed a part of his arms, but I think I made my point very clear. These are wingless tumors in children, specifically age less than 16, classic histology, and there are no mets. These tumors are low risk. Hence, they are coded green. Okay? Then we move on to the next slide. These are more than 16. WNT, more than 16. Classic histology, no mets. These are standard risk. How do you remember this? This is a guy who is, we are assuming that he's a guy more than 16 years of age. You see that his wings have been cut off very brutally. There are no mets. He is a classic. And this one is a standard risk. How do we know? Because it's coded yellow. We go back to the previous slide so that we remember this in the group. Let me go back. So we come back to the same slide. You all can follow my cursor. This one was the first line. We are going like this in this direction. We remember that SHH TP53 wild type is a standard risk age group. Standard risk group. Then we have TP53 mutants, which were a high risk group, but they were uncommon. And then we have WNT group, where if the age is 16 and there are no mets, then it is a low risk group. But if the age is more than 16, looking like that poor guy, then it is a standard risk age group. Are you all with me so far?
Yes.
Yes.
Tell me to slow down if you don't understand anything. It's very important that we can go back and correlate it with the actual chart. Group 3 is the easiest. Classic histology, standard risk. The yellow color. Group 4, classic histology, no mets, but favorable findings. This means they are a low risk group. What are the favorable findings? Chromosome 7 gain, chromosome 8 loss, chromosome 11 loss, chromosome 17 gain. If you don't remember the findings, that's okay, but you should just remember that if it is group 4 with a classic histology, there are no mets, and there are favorable findings, then this means this is a low risk group. Whereas if this is a classic histology, there are still no mets. Compare it from the previous group. No mets in the low risk group, no mets in the standard risk group. What's the difference? The difference is only favorable chromosome findings. They were present in the low risk group. They are absent in the standard risk group. Okay? Group 4, classic histology, but there are mets upgraded to the high risk group. So we have 3 groups in the group 4. There is a low risk group, there is a standard risk group, and then there is a high risk group. Low risk is when there is classic histology but no mets and favorable findings. Standard risk is when there is classic histology, no mets, but no favorable chromosomal findings. Group 4 high risk is when there's classic histology but mets are present. Let me go back to the chart. So we were going in this direction. We have almost reached our destination for the first row. You all remember till here? We were here, group 3, easy peasy. It's all yellow, standard risk. Classic histology, group 3, standard risk. Group 4, what did we say? It's low risk when it's classic histology and no mets, and favorable findings. Did you all notice this small c that Greenberg conveniently placed here? And then we have the standard risk where we have no mets, but also no chromosomal findings. And then we have high risk group where we have mets. Okay? We have finished the first row, which was the classic histology and probably the hardest ones. Rest of them are a piece of cake. Let me change the slide and go back. So we move on to the next row. What was the next row? Large cell or anaplastic histology. There are only 2 groups here. Sonic hedgehog, TP53 mutant, large cell or anaplastic histology, they are a very high risk group. We already know it. TP53 mutants behave in a very high risk manner, more so if their histology is large cell or anaplastic. They were not exactly well behaved when the histology were classic. Large cell or anaplastic histology is an independent poor prognostic factor. So when you add this, when you add this plus this makes a very dangerous tumor because this is 1 plus 1 equals to 11. There is synergy happening here. So there are only 2 groups here. We are going to move forward to the next group. This is group 3. Large cell or anaplastic histology, but no mets, it's high risk. So these are the only two groups that were present in this histology. I'll go back quickly. TP53 mutants, large cell anaplastic histology, they are very high risk. Group 3, nomads, large cell anaplastic histology, they are high risk. Now we go back to the dreaded chart, which doesn't look as dreaded anymore. And we can see that there are only two groups here in this group of histology. TP53 mutants, sonic hedgehogs, which is a very high risk group. Group 3, high risk when no mets, and very high risk when mets. I think that's the next slide. So we have finished almost more than half the chart. Let me move to the next one. So, group 3, large cell anaplastic histology with mets, very high risk. We just saw that on the main chart. Moving on to the next histology group, desmoplastic or nodular. TP53 wild type, desmoplastic or nodular histology in infants. If you notice, this looks like a younger version of the sonic hedgehog. These are cute, they are infants, and they are low risk. Consider infants and the low risk or benign etiology in the same manner. Extensive nodularity histology. These are TP53 wild type. In infants, low risk. So we have finished the chart. I'll go back and summarize it. We did this, then we did this. These here are very rare. Even if you ignore them, that's completely okay. We did these two groups, TP53 mutants, sonic hedgehogs. We also did this group 3, where if there are no mets, it's a high-risk group. If there are mets, they are a very high-risk group. And then we saw that for infants, if there's desmoplastic or nodular histology, or if there is extensive nodularity histology, both of them make it a low-risk group. So, does this chart look as scary to you? It's not, it's a cute chart.
No.
I'll upload the PPT. You can always go back. They are not open to download, but they are open to viewing. You can open them in Google Slides and view them, revise them so that you don't end up forgetting. Anybody who is appearing in the theory exams that are going to be happening in probably 2 weeks, this chart is going to help you a lot. So moving on to the more interesting part. Investigations, we all know a piece of cake. We get a CT, we get an MRI brain with contrast. We also get the entire craniospinal axis imaging. What does the CT show? We have discussed the radiology in thorough detail in the previous session. I'll just go over it briefly. There will be a hyperdense lesion due to high cellularity. Because medulloblastomas are highly cellular lesions, they are hyperdense on CT and they also show diffusion restriction. Always remember, any lesion which is densely cellular or which has a small compact cells, it is going to appear bright on DWI because there is going to be diffusion restriction. So that was an off point, by the way. CT non-contrast shows a hyperdense lesion. On contrast, most lesions enhance. Approximately 20% show calcifications. And why don't we favor CT? Because CT has very poor posterior fossa resolution because of the bony artifact, but it's a good modality when the patient is also presenting to you with simultaneous hydrocephalus features and you want a quick investigation. So, MRI brain with contrast is gold standard. Signals are variable. On T1, it is hypo to iso. On T2, it is heterogeneous because of the cyst, the vessels, the calcifications. Most lesions enhance after contrast, but even if they don't enhance, they still are a grade 4 tumor, which is a recurring pattern that we have discussed throughout these sessions. Enhancement is not a good indicator of the grade of the lesion. MRS shows elevated choline with reduced NAA, very typical for any high-grade tumors. So, post-op risk stratification, why is this here? This is here because these are the same groups: the standard risk tumor, the low risk tumors, the high risk, or the very high risk tumors. So the standard ones, let me turn on my annotation. So what are the standard risk tumors? You have done a near total resection or a gross total resection. There are no METs. There are no tumor cells in the CSF that we do 2 weeks postoperatively. There is no evidence of extra CNS METs, essentially no metastasis. So you have done, let me clear this one. You have done a gross total resection, plus there are no METs in whatsoever form, because all these are telling us some form or the other of metastasis. Apart from these two elements, what else do we need? It's either going to be a sonic hedgehog, wild type, with classic histology, easy. Remember the yellow one, the yellow sonic hedgehog? Or it's either going to be a group 4 with classic histology and no METs at diagnosis and no favorable chromosomal findings. Why is this important? Because if there were favorable chromosomal findings, it would have been labeled as low risk, which we are going to come to. Then we have group 3. We remember that group 3 with classic histology was a standard risk tumor, the easiest one in the group, or it's going to be a wingless tumor with classic histology, age more than 60 years. You all remember the sad guy with cut off wings? He had a standard risk profile. So we move on to the next slide. These are the low risk tumors. Let me start my marker. So the first one is wingless WNT activated group. Leave these if you don't remember, that's perfectly fine. You only need to know this. Or SHH activated TP53 wild type in infants, we know this, with either histology. Both the desmoplastic or extensive nodularity were low risk groups in the infants. And you have done a total or near total surgical resection. It's completely okay if it's all getting mumbled up in your brain. You're not going to retain this in the first listening. You will have to go back, take a look at it, and I will upload the recording. You would have to listen to it and read yourself. But hopefully, this will help you in retaining most of it. So these are the high-risk tumors. Large cell anaplastic histology. This guy here is a big red flag. Then we have group 3 tumors without METs, or classic histology, sonic hedgehog, TP53 mutants, or group 4 with METs. Or probably the more important ones that were not in that table, if the tumor is unresectable, or if the residual tumor is more than 1.5 centimeters square. So this, apart from the first chart, also makes them a high-risk tumor, and extra CNS metastasis also makes them a high-risk tumor. Notice how just the presence of extra CNS mets is not upgrading it to the very high-risk group. It's upgrading it only to the high-risk tumors. So very high-risk tumors, large cell anaplastic histology, TP53 mutants, or group 3 with METs. There are only 2. Okay, I'll clear this and we will move on. Let's continue rest of the medulloblastoma tomorrow. Hopefully it's going to be the last of our sessions regarding medulloblastoma, but this one was difficult and I wanted to go slow and help all of you in remembering and retaining all of it. So somebody has sent this emoji in the chat box, which is going dizzy. That's perfectly okay. That's perfectly okay. It's not going to make a lot of sense. And people who are going to appear in the exams, this might help them. If you're not appearing in exams, it's okay if you don't end up remembering everything, but you will remember some portion of it. So does anyone have any questions? Any questions, any feedback?
I have one question. What are the most common extra CNS mets for medulloblastomas?
Most common extra CNS mets are usually due to the VP shunting in the peritoneum. Somebody has answered that in the chat box as well, and I think this is Dr. Fatma. Yes. Any other question?
Yes, ma'am, I have a question.
Okay.
Ependymomas and medulloblastomas both are showing patchy contrast enhancement in the post-contrast images. And medulloblastoma also going to the foramen of Leschka. So how we will differentiate between them?
We are going to differentiate in terms of the radiological presentation. Ependymomas have more calcification in comparison with medulloblastomas. The enhancement pattern is also more heterogeneous for medulloblastomas because it has more of cysts and vessels and calcifications. Ependymomas show slightly more homogeneous enhancement, but we are going to have it tomorrow in the presentation as well, a side-by-side comparison of ependymomas and medulloblastomas, their radiological features, and how do we differentiate them. That's already a topic of tomorrow's presentation.
Thank you, ma'am. Thank you.
Also, there is banana sign, but let's discuss that tomorrow in detail. So, any more questions or feedback?
It was a very good session. I've taken this for the first time. So really thank you for that.
Thank you so much. So everyone, this is a wrap. We will see if we can wrap up medulloblastomas tomorrow and start something else and more interesting from onwards. But let's see. Let's not make any quick assumptions. Thank you, everyone. Have a good day. Have a good night, whatever time zone you're in. Thank you so much.
Thank you.
Thank you.